We are ready to begin, and on behalf of our Dean, Boris Luzniak, and the Department of Family Science, I want to welcome you to Public Health Grand Rounds today. I'm Sandra Quinn. I'm the professor in family science and the chair of the department as well. The new and very daunted chair and excited chair of the department. So it is my great pleasure to host today Dr. Carolyn Halpern. She is the chair and professor in the Department of Maternal and Child Health at the Gillings School of Global Public Health in Chapel Hill. I was a faculty member there in one of her sister departments, so I literally the floor above my office was their office. So this is a long-standing department, about 56 years? 66. But let me tell you about Dr. Halpern. She is a developmental psychologist. Her research aims to improve the understanding of healthy sexual development and the implications of adolescent experience for developmental and demographic processes into adulthood. She's the deputy director and co-investigator of waves 4 and 5 of the National Longitudinal Study of Adolescent to Adult Health, called AD study for those of you, who don't operate in this world. It's a program project grant. And she's co-PI of a newly launched, funded R01, the sexual orientation/gender identity, social economic status, and health across the life course. That's funded by the National Institute of Child and Human Development and the National Institute of Minority Health and Health Disparities. Before her work on Ad Health, she directed 2 U.S.-based longitudinal studies examining pubertal changes and their implications for adolescent sexual and psychosocial development, as well as a global longitudinal data collection project assessing the potential of the web for improving adolescent knowledge on sexual and reproductive health. She's the author or co-author of 13 book chapters, over 135 peer-reviewed publications. So we are really excited and honored to have her here today. What we're going to do is she will speak for about 45 minutes, and then we will have time for discussion. At 2:30 we'll break, and we will have a reception out in the hallways. So I invite you also to stay for that. So Dr. Halpern.
Thank you, Sandra. That lovely introduction. It's nice to be here. I've had a great day so far, so I'm looking forward to telling you a little bit more about my work. What I thought I would do is kind of give you an overview of the main takeaways from the work that I've been doing with my students for the past 6 or so years. And I would very much welcome your insights into kind of when it's all said and done, what should we take away from this? Because I am still struggling with that a little bit. And then if time, I want to talk a little bit about the new project on sexual orientation that Sandra mentioned. It was a long time coming, and we're very excited about getting started on it finally. So let me see, get organized here. So we now have almost 50 years of research on adolescent sexuality behind us, and there are thousands of articles and book chapters. I think I did a quick Web of Science, 22,000 articles with adolescent and sex in it. But because it was largely, I think the research line was largely prompted by increases in adolescent pregnancy. And adolescent pregnancy obviously is a public health issue. So it sort of framed adolescent sexuality as a problematic behavior, or a behavior that is of social concern and should have some social control imposed on it. So that meant that the foci of that research line would be on transition to first vaginal intercourse, failure to use contraceptives, negative health outcomes like STIs and unintended pregnancies and adolescent childbearing. These are all legitimate concerns because there are certainly public health issues and problems that arise from this. But it's not necessarily the case that understanding these challenges and problems is incompatible with also thinking about adolescent sexuality as a normative part of development, as a biopsychosocial phenomenon. My stance, and I think that of many others, is that this separation between adolescence and young adult, or emerging adulthood and adulthood is kind of an artificial distinction. It's much more blurred than that and variable by the individual. So happily, in beginning in the 1980s, and with increasing voices, there was a desire to reframe adolescent sexuality as a normative part of development. And what that meant was that we could start thinking about other things than just vaginal intercourse and its timing and what that meant in terms of STIs and pregnancies. So it's not just vaginal sex anymore. We can have more attention to motivation and desire and pleasure and agency and relationship-based research. I think it's a very positive turn of research lines for this area. So let's see. So along this vein, in my work, as I started thinking about this project that I wanted to take on, I asked myself several questions, and that is, how do adolescents start their sexual lives? How common are different behaviors during adolescence? Does the sequence of behavioral initiation make any difference? Does the pace make any difference? Does the pattern of getting started make a difference? And are there different health implications? I'm sorry, I'm having trouble getting in sync here. Are there different health implications for different kinds of patterns of getting started? So this shows the basic kind of conceptual model that I've been using to try to apply a more holistic approach to looking at sexual health patterns and what they mean for adolescent health. So first, in terms of getting started, all those elements that I mentioned earlier, not just vaginal behavior, but oral sex, anal sex, and the sequences. So we're looking to try to broaden what getting started looks like. Do those patterns make any difference for health outcomes later? And if so, what's the pathway by which those implications take place? So first, let me tell you a little bit about the study that I've been using to address these questions. As Sandra mentioned, it's the National Longitudinal Study of Adolescent to Adult Health, or AdHealth. It's a nationally representative, prospective longitudinal study of U.S. adolescents who were in the 7th through 12th grades in the 1994-95 school year. Our statistician recently reminded one of my doctoral students that is the representative sample. It's not a current cohort, but so we always have to make sure we say those details. To date, there's been 1 in-school interview and 4 in-home interviews, and we're currently in the field for wave 5. Our respondents are now in their 30s and early 40s. And we're starting to work on a wave 6 application, which our hope is that it can transition into an aging study. So I won't go through all the details here, but this is the original sampling frame for AdHealth. I'm sure some of you are very familiar with this, others may not be. But as you can see, it was originally a school-based study with a very complex sampling design, oversamples of a variety of populations. There's a population with disabilities, there's oversampling of certain ethnic groups. There's a twins sample within the broader sample. And then, oops, sorry. So this shows the longitudinal design of AdHealth, starting with the in-school questionnaire, and then on your left you can see each of the waves, the years in which they occurred, and the recruitment rate for those waves. And then on the far right you can get a sense of how old the adolescents were at each wave and how many participants were in that wave. So it's we've actually had amazingly good retention. In wave 4, we had 80% retention from the original eligible sample. So it was hard to do that. It was complicated, but and RTI was our subcontractor and did a great job with that. So let me tell you a few sort of initial things that we've done to look at varieties of behavior that exist during adolescence. So this shows the first sexual experience by age 18 in the adolescent cohort, broken down by biological sex. And you can see that almost 20% of the sample hasn't had any kind of experience by age 18, whether it's vaginal, oral, or anal sex. And then as you move on, for some, about 15% overall, oral sex is the first experience they have. For a much larger proportion, vaginal sex is the first experience they have. And others experience both oral and vaginal at the same age. And that's, putting it that way, is partly a function of the way the question is asked in Ad Health. You report the age at which this experience first occurred. So if you say 15 for oral and 15 for vaginal, it's not clear if it happened at the same time, or so you can't really separate the two. So, but you can see there are sex differences in what these patterns look like. But the main takeaway is that it's kind of all over the place. Some are totally inexperienced, and others are starting their sexual lives in different ways. And another early kind of thing we did in terms of looking at sequence, we were curious about whether starting oral sex first and waiting at least a year before another behavior made any difference versus starting vaginal sex first. So this plots the probability of a teen pregnancy for students who fall into those different categories. So on the far left is vaginal sex first, then 2 behaviors in the same year, and oral sex first and then waiting a year. And there's a significantly lower probability of a teen pregnancy when you fall into that oral sex pattern. So this suggested that sequence may make some difference in terms of health outcomes. So it was essentially, this was something worth pursuing. So we decided we wanted to get a little more holistic about it and try to bring some of these characteristics together rather than just looking at one thing at a time. So we decided that we would do a person-centered analysis or a latent class analysis. I'm sure most of you are familiar with this. It assumes that there's an underlying construct that's not observable, but that there are observable indicators that you can use to try to get at that construct. And a probability of someone being in one class versus another class just depends on where they stand in terms of those indicators. So what was attractive about this to us was that we could try to pull in multiple pieces at the same time and try to understand whether, excuse me, whether adolescents who looked similar behaviorally would first, are there classes of adolescents who look similar? And then if so, what does that mean in terms of their health later on? So these are the indicators that we used for the latent class analysis. It's pretty much what I had mentioned before. I didn't go into detail about the timing of the first behavior. So is it oral sex? Is it something else? The pace. How long does it take from the first behavior to the next behavior? And whether they had anal sex before age 18. And I guess I was going to say, I could stop if people have questions that were to clarify. Yes?
Question, when you were talking about pregnancy, as far as the males, was that just looking at the females, or was there a unintended pregnancy measure for male adolescents?
Sorry, that's a good question. Thank you for clarifying. It's only females. Yeah, it's only females. We do ask those questions of males in Ad Health, but there are different challenges with getting information from males versus females. So, but that analysis was just females. So, so we put all these pieces into a latent class analysis, and along with a lot of this is in collaboration with my wonderful doctoral students who I've had over the years. So, Abigail Hayden this was part of her dissertation. So we did a latent class analysis, came up with 5 classes that were distinguishable and captured 80% of the variation in the indicators that we were looking at. You can see that they vary quite a bit in size. The modal class is the vaginal initiator multiple behavior class, which is almost half of the sample. And let me show you some of the, so you can see they vary in terms of the mean age of first sex. I'm sorry, I'm having trouble seeing that and seeing this. So the modal group has about 15.7 years of age at their first experience. It may be vaginal sex, it may be something else. And in contrast to the other two extremes, which is the postponers, where it's almost 22, age 22 before their first experience, and 15 on the other end for the early atypical. The first behavior varies a little bit across the classes. The time to second behavior has some variation, and the number of behaviors in their repertoire up to that point has some variation. And then the other piece was how many had anal sex by age 18. So you can see the early atypical group is labeled that because they're the earliest to get started, and they're unusual compared to the other classes because virtually all of them have had anal sex before age 18 in that class. So we've been doing a lot of work based on these latent classes and trying to understand if those particular patterns that you see with these different indicators make any difference. So, but first we wanted to see, okay, who lands in these classes? What do they look like in terms of what predicts being a postponer versus being in that modal class versus being an early atypical? So we turn to, and always have to sort of like, I'm sorry. Yeah, we don't think of adolescent sexuality as a problem behavior, but on the other hand, it's a great theory to try to frame how different pieces of the adolescent's environment comes together to help drive their behavior. So we wanted to look at whether what other kinds of characteristics apply to adolescents who fall into these classes. So we did use problem behavior theory. And as you probably know, there are three domains: personality, behavior, and the perceived environment. And I've just listed here some examples of the kinds of indicators that fall into those different domains. And the idea is that interactions across these domains lead to either psychosocial conventionality or unconventionality, or kind of a proneness to be unconventional in your behavior. So we took in so we did an analysis where latent class membership is the outcome, and psychosocial conventionality based on those three domains is for personality 8 indicators, six for behavior, and 4 for the perceived environment. These are all the predictors in trying to understand which class people land in. Pubertal timing, BMI, perceived weight, demographics, basic demographics. We did a multinomial regression stratified by sex to just see what was associated with membership in these classes. And what I can tell you is there wasn't much. All these indicators, and what we found was that there were a lot of, this class is different from this class on this one thing here, but they're not different from another class on this other attribute. So there were only a few things that were sort of consistently coming up as far as predictors. For males, in the postponers class, they tended to be a little bit older. They tended to be they're more likely to be overweight. And they were more likely to be religious as measured by weekly service attendance. For females, they also were a bit older, but they reported better relationships with parents, and in a way that we wouldn't have expected. They actually reported lower expectations for achievement. And these were the only things that sort of consistently distinguished across the classes versus the other sort of haphazard, items that might show up here and not there, which was not what we expected. I mean, we really thought there would be kind of a, coherent. If you're a postponer, then you're going to be showing the higher scores on psychosocial conventionality versus the early atypical, and that's not how it played out. It seems like there's some combination of opportunity kinds of indicators as well as value, behavior, value and attitude kind of indicators. So turning to the health implications of these initiation patterns, we tried to look at both negative and positive health outcomes to see if they were associated with initiation patterns. And this is a summary table from multiple different models looking at different outcomes. So we looked at multiple reproductive health outcomes, whether there were concurrent sexual relationships, STI diagnosis in the past 12 months, lifetime incidence of exchanging sex for money, numbers of partners, and pre-18 sex partners. And you can see for some classes there's a pretty consistent trend. The postponers fare better on all of these outcomes than persons in the modal class. These are all compared to the modal vaginal initiator multiple behavior class. And the top group there, vaginal initiators, single behaviors, they also tend to fare better on these negative outcomes. But what's interesting, I think, is that the group that you would think, well, these may be the most at-risk kids because they're starting very early, they're doing behaviors that are not typical of other adolescents, but they were only different from that modal class on one outcome, and that was the concurrent partnerships in the past 12 months. So it's not what we expected to find. And on the positive side, there wasn't much, actually, which is interesting. The class membership didn't predict a lot, but you see some advantage for the postponer class, again, in terms of looking at relationship satisfaction compared to the modal group. They were a little bit higher. But the early atypical don't report lesser relationship satisfaction compared to that group. And then same thing with sexual satisfaction. So it's interesting that there's really, there seems to be some advantage for the postponers. Maybe that's because since they're starting a little bit later, they're a little more mature, they've had more opportunity to learn how to navigate relationships in a pro-social kind of way. But you wouldn't necessarily expect that the early atypical wouldn't differ from this normative class. So we thought, why is that? So of course, the piece that's missing here is what comes in between getting started and the young adult health outcomes that we were looking at. So we wanted to try to look at the association between class membership and the behavioral pathways that people take afterwards. I mean, in some research, people look at usually timing of first vaginal sex, but that's broadening a little bit. But you'll look at one thing at a time, how early did you start and what is the outcome like? Or how many partners have you had and what is the outcome? But it's less common to try to pull these things together and look at both at the same time to see if a certain combination of these patterns makes a difference versus just one single indicator. And so that's what we were hoping to do with this work. And so this shows how the percentages of each of those initiation classes and the number of sexual partners that they report lifetime. So the really pink color is 1 to 3 partners. The lighter pink color is 4 to 7 partners, and the orangey kind of color is 8 or more partners. And although there are differences across the classes, and at the far right is the total, what was interesting, I think, was that there are differences, and some are more likely to have this number of partners versus another, but there's variation within each of those initiation classes. So not everyone in the early atypical initiators is having lots and lots of partners. There are plenty who just have 1 to 3 partners and look very much like the postponers or the modal class. So it suggested that people could start one way and go down different pathways in their subsequent behavior, and maybe again the combination of those two things might make a difference for their health outcomes. So we decided to, since this is kind of unyieldy, and to be frank, the differences between those, like the dual initiators and the vaginal initiator single behaviors, are not as distinct as some of those, the kind of outlier categories. We decided to focus on just 3 classes, the modal class, the postponers, and the early atypical. So here's what most people are doing, and then the kind of the extremes to try to understand what might be happening. And so we sort of approached this with this idea of you can start in one place and end up in the same place, or you can end up in very different places depending on kind of what comes in between. So we wanted to be open to different possibilities. And thinking about it, I mean, I still think that there's some conventionality issues here that are relevant, although our analysis didn't heavily support that. So we wanted to look at the combination of numbers of partners and class membership. So we basically looked at an interaction between the two. And so this shows the odds of a lifetime STI among those combinations. The referent group is the modal vaginal initiators, multiple behaviors with 4 to 7 partners, that's the modal numbers of partners in this cohort, and looked at how you can sort of think about it, within those categories of partners, how do the different initiation classes look? And you can see that I'm sorry, I'm having trouble seeing things. That's the early atypical. No. Yeah, thank you. So the vaginal, the modal group, if they have fewer partners, then they are less likely to have an STI than the persons in the same group who have 4 to 7 partners. And similarly, if they're in that same class but they have more partners, they're more likely to have an STI. So within the modal group, numbers of partners seems to make a difference. You're at higher risk if you have more partners. But what's interesting is the early atypical, if they've had 8 or more partners, they are also at higher risk for an STI compared to the modal group with 4 to 7 partners. But what's interesting is for the other groups, they're not at higher risk. So even though they're or lower risk for that matter, the numbers of partners doesn't seem to matter at that lower end. And for the postponers, it doesn't matter at all. It doesn't matter how many partners they have. They're not different in terms of getting an STI. And then here's a same analysis, but looking at unintended pregnancy. And you see basically some similar patterns. The fewer partners in that modal group, less likelihood of an unintended pregnancy. More partners, higher likelihood. And for the early atypical, there's a higher likelihood as well. So there's kind of a consistent pattern here where the numbers of partners makes a difference for some groups, but not for others. Okay, and then finally, we looked at relationship quality. And again, fewer partners, there's a report of higher relationship quality in that modal group, and lower quality in the high partner group for the modal group. And early atypicals look like although the confidence interval is larger, they look more like the modal group if there are fewer partners. Does this all make sense? I feel like I'm forgetting to say some stuff. I mean, so you can understand the graphs that I'm showing you.
Is this, can you just remind us, this is across all waves, or this is from wave 1?
It's some of the reports are actually from wave 4 because we needed those reports at wave 4 about age at onset of the different behaviors in order to lay out the groups. So it's
The lifetime partners, I'm just trying to, is up until they're to the current age, or is it? So if they're.
It's what they report in the Wave 4 interview. And of course, people are different ages at Wave 4, and so all of the models control for kind of exposure time because they do vary in their age. Yeah, thank you for asking that. So going back to the model that we first talked about, so we came up with 5 initiation classes that seem to be distinct. They do have variations in the kind of partnering patterns that they show afterwards. And there is some variation in health outcomes by thinking about the combination of both how youth get started on sexuality and what they do afterwards. So here's the part where I would love to have your input. So a couple of things, a couple of observations. One is that early start is not necessarily problematic. I mean, I think oftentimes we kind of assume that if there's early initiation, I mean, we know that it's higher risk, but we assume that it is, like doom. So this suggests that that's not the case. There may be some adverse consequences in adolescence, but they likely diminish with experience and growing maturity. And to give you an example, I want to show you, this is some earlier work from one of my other fabulous doctoral students, Christine Casel, who's now at Virginia Tech. So she looked at the association between age at first vaginal intercourse and testing positive for an STI. And so the lines show respondents who initiated at different ages, from anywhere from 12 to 19, and their odds ratio of an STI at these different ages. So you can see at around age 18, it makes a big difference. If you initiated early, you're much more likely to test positive for an STI. But if you look later, among 24-year-olds, there's no difference. And again, you have to, I guess, think more about what's coming in between there. But it's just to kind of reemphasize the point that an early start doesn't necessarily that there are lingering implications of that start, even if there are some during adolescence. And then we have some evidence that a later start does seem to hold some benefits in terms of some advantages in terms of maturational readiness, but I have to say that the differences that I've been describing, maybe except for the unintended pregnancy and sequence, most of the differences are not huge. They're statistically significant, but they're not hugely different. And it's a large sample, so you don't have to have a big effect to get a statistically significant association. So we're still trying to sort of reflect on what does this mean in terms of, the whole idea was let's try to have a more holistic approach to thinking about how kids get started, what they do afterwards, and what that means in terms of their health outcomes later. It's not a clear story. It's not a really clear story. And so maybe when we get to the question and answer period, because there's one more piece I want to tell you about, I would love to hear your thoughts about what does this mean? Does it mean that it really doesn't matter? Does it mean that we're not looking at things we need to look at in order to better fill in the picture? That's a conversation I'd love to have. But I wanted to tell you a little bit about a new project that we're starting that we're really excited about. This is the one that Sandra mentioned in her introduction. So we wanted to try to capitalize on the AdHealth data to get information about the sexual minorities who were in that sample. And I'm sure you know, there's a lot of evidence that there are multiple health disparities among gay, bisexual, lesbian, adolescents, and heterosexual. So violence, substance use, mental health, HIV, barriers to health care, and bisexual women are actually at elevated odds for teen pregnancy compared to heterosexual women. So, why? What is it that's driving this? And the problem has two things. One, I and my colleague, Kareth Conran at the Williams Institute, who is my co-PI on this project, our hypothesis is that one of the drivers of this is socioeconomic status. And it's interesting, it's not a piece that's been well studied as a potential contributor to these disparities. And part of that is that there is a lack of data that will lend itself to really getting at this problem. So, the census gets some information about same-sex households, but you can't tell what the relationship is necessarily between the two same-sex people in that household. There are other cross-sectional studies that measure identity, but there's no kind of one data set that captures identity and SES indicators and family relationships and developmental pathways into adulthood. And the longitudinal studies that do exist are not population-based. So I had this kind of light bulb moment where I thought, we could use AdHealth to look at these people, because there are about, depending on how you measure it and when you measure it, there are about 2,000 sexual minorities in AdHealth. It's very unique in that they were not sampled because they're sexual minorities. They just happen to be in the sample because it's a large population-based sample. Because a lot of studies, that's one of the issues, is that you go to a gay rights rally or something to recruit participants, and obviously those are not necessarily the same people who you're going to find in the population. So it's it allows for a prospective look at sexual minorities that is very unusual. So the aims of the project are to first develop a new survey module that will help us. AdHealth has a lot of great data that intersects with the questions that we're trying to answer, but it's missing some stuff. One of the things one of the domains that's missing is looking at those developmental markers. We can look at same and opposite sex attraction as reported over time. We can look at sex of partners as reported over time. And starting when they're 18 to 26, we can look at their identity in terms of sexual orientation. But we know very little about the developmental path that got them to that orientation. So one of the goals is to develop a new survey module that would capture the developmental kinds of landmarkers that are not currently available in AdHealth, and also to look in greater depth at some of the economic indicators that are not currently in AdHealth. So, for example, it may be that the likelihood of intergenerational transfers of funds or resources is different for a sexual minority versus a heterosexual. If you're estranged from your parent, maybe they don't want to pay for your wedding, or maybe they don't. You need in vitro fertilization to bear children. So there may be different health costs, there may be different resources that come your way. And so we would like to capture additional information that would help us get at that. So we're developing a new survey module. We're going to conduct an ancillary interview where we target the sexual minorities in the sample and a comparison sample of 1,500 heterosexuals. And one of the kind of fun things we're working on right now is, originally our plan in the application was that, okay, we'll get people who identify as a sexual minority at wave 4 when they're 24 to 32, and then we'll capture any newly identified in wave 5, and that'll be our sample. But we got to talking about it with Paul Beamer, our statistician at RTI, and we were thinking, well, these different measures, each one is sort of problematic. It's a single measure. It's at one point in time. What kind of measurement error might there be across these different indicators? And we know that things change a lot over time. We just did a crosstabs on wave 4 and wave 5, and there are people who identify as a minority as an adult in wave 4 who do not identify that way in wave 5, and vice versa. So it's an interesting thing to kind of grapple with developmentally. So we had this great idea that we would do a latent class analysis on all the indicators that might pertain to this status and try to understand essentially the probability of being a sexual minority or not, taking advantage of more indicators than just one self-report, and looking at being able to capture, to capitalize on the longitudinal data that's available in AdHealth. So we haven't started that analysis yet, but hopefully it won't get 5 classes. They're like, ugh, you can't figure out where you are. We'll go back to our simple thing, but I think it's exciting because I think it's a new approach to trying to, to classify people into these groups. And then we'll also prepare documentation. AdHealth has a policy where any data that are collected after they're cleaned and ready to go, then they're made available to AdHealth users. And so that'll be the same with these data. We'll collect these data, we'll clean them, we'll provide the documentation for them. Once that's all good to go, then they will all be available to AdHealth users. So we're excited about this. We feel like it's hopefully a great resource to add to the data set that will help a lot of users who are interested in these topics. And finally, there is one substantive piece where we're trying to apply minority stress theory to look at, if there are problems in parent relationship quality, what does that do in terms of intergenerational economic transfers? How does identity feed into that relationship? Is there discrimination? Lack of resources means stress. So pulling all those pieces of stressors together to look at what that means in terms of health outcomes. In this project, we're focusing on mental health, but of course, there's a lot of health outcomes that are captured in AdHealth, and you could use the same model for a lot of different health outcomes. So that's what we're getting ready to start. We're very excited about it. I want to just put my usual acknowledgments for AdHealth. NICHD has supported a lot of AdHealth, and they and the NIMHD are the co-sponsors of this new project. So I will stop there so we can talk. Thank you.
So this is your time to ask questions of Dr. Halpern, and floor is open, Dr. Todd.
Fascinating topic, talking about sex.
It always draws a crowd.
So, just to kind of break it down for me, what myths were dispelled in your data? So, if I were to stop 9 out of 10 people on the street, they would think that minority kids have sex earlier. They would think that minority kids have more STIs. I go down the whole list of horribles, okay? So my question to you is, did your data dispel these myths or confirm them?
Okay.
That's one.
Okay.
And the other
I better write this down.
This has to do with region. I would think that those in the Bible Belt, I might predict those in the Bible Belt are in your, a certain one of your categories, which is folks out in California. That's my uninformed.
Yeah.
Did your data can it confirm those kinds of things about region?
It's complicated, but there's certainly, if you just look at prevalence, then you do see differences by race, ethnicity in terms of STIs. So there are routinely documented differences, but that's kind of an isolation of other factors. I mean, it's that concept of race captures lots of stuff. So I think you need to dig deeper and try to understand what are all the factors that may feed into this. There are definitely demographic and regional differences in terms of membership among the classes. One of the things we looked at in those initiation classes, one of the things we looked at the beginning was, will the structure of the classes be the same for males and females? Will it be the same for the different race groups in AdHealth? We didn't look at region actually as a potential way to structure it, but the structure looks the same across those demographic groups. However, the membership of the different classes does vary to some extent. And so that's where we do have to include demographic covariates in all the models that we run, because there is, for example, African American males are more likely to be in the vaginal initiator single behavior category than white males are. I'm not sure exactly what that means. Presumably some cultural differences in terms of expectations and normative behavior. So there is some variation. I don't know that, I guess in terms of dispelling a myth, I think the myth would be that I think did dispel was that one, that an early start, no matter what kind of behavior it is going to doom you to poor health outcomes is wrong. And that lots of partners isn't necessarily going to doom you to poor health outcomes. It depends. It's both of those things, and I think all the contextual information that we were not really able to apply to these analyses. So, maybe someone in the early atypical class was in a relationship with one person for a long time. Maybe it was a very healthy relationship, and that's a contributor to why it didn't play out in the way that you might think if it was, a less stable kind of relationship. So those are, I think for me, those are the big things in terms of dispelling myths, that there's different ways to get to the same point, and that varies across people and their characteristics. And so I think it's something we need to keep in mind in terms of programs and interventions.
Okay.
I saw you first, and then I'll come back.
Thank you. Really interesting. Thank you so much. I'm wondering if you collected any data on peer influence and social networks and the role that those might play in. I was thinking specifically about your different classes.
There's definitely rich data in Ad Health about peer networks for the adolescent period. Within Ad Health, there were 16 what's called saturated schools, where everyone in the school completed the same survey and listed their friends. So you can actually do sociometric analyses with friends. We haven't done that, but that's an interesting idea. I mean, you could go back to the adolescent data, look at their friends and what their friends are doing, and then apply that to either these kinds of analyses or others. Because certainly, it's it presumably is an important factor. One of the challenges, of course, is the classic: is it selection or is it influence? Do you select friends who behave like you do because you're comfortable, or are you influenced by friends who are behaving differently? And that's something you really can't peel apart very well in Ad Health, but the network part you definitely can.
Yeah, I had, I'm sorry, I missed the first few minutes of your presentation, so I apologize if this was addressed. But it may piggyback on this one in terms of the romantic or lack thereof relationship context for the people in your studies. That's one of the things in my reading of that literature is that you sort of, sexual behavior is sort of like classified out as purely a risk behavior, or it's looked at in concert with other kinds of risk behaviors such as alcohol and drug use and things of that nature. And so what kind of gets missed is the fact that there is some relationship context, whether it's a casual one or it's a more extended romantic relationship context that can lead to the initiation of sexual behaviors. And the whole hookup with culture thing, notwithstanding, it's a more recent term, but if you could speak to, if not with these data, your sense of how is that happening for the young people in your study?
Yeah, it's a really important point because obviously the relationship context makes a difference. The role models you've had for relationships makes a difference. So all of those things are really important. In the context of the Ad Health data, that's a limitation. We don't know, for example, it may be that some of the members of the early atypical class, their first experience may not have been consensual. And so it may be that it's not that they're a, an impulsive risk-taking kind of person, but rather they were vulnerable to somebody. And unfortunately, it's not possible to determine if the first, certainly not even the first vaginal, but even the other kinds of sexual behavior, it's not possible to determine if it was consensual or not, which is a huge factor in terms of how things play out later in health. It's a significant limitation of the data that frustrates me all the time. So, but definitely all of those factors are so important, and it's just hard to. I think that's where smaller scale studies and maybe qualitative studies. I mean, I'm sort of the mind that we need all of these kinds of studies. We need large studies to get population kind of trends and be able to, to look at diversity at the same time. But on the other hand, we also need smaller scale studies that can really dig deeper into some of these contextual pieces that really are critical. I mean, that's if I were going to say what's the big limitation of these analyses, that's it. We can't contextualize it in the way that we would like to. Yes.
Thank you very much. It's a really interesting talk. So I was just curious. A lot of these behaviors are sensitive behaviors, sensitive issues. I do work around. I've done work around pregnancy outcomes and subsequent analysis of abortion versus delivery, using nationally representative data. And there are studies that publish that say that have found that up to anywhere from a range of 35 to 50% of actual abortions are underreported on national surveys. So I guess I would just be curious to know if you think how I guess accurate can the findings really be, or has there been any analysis to sort of determine whether or not people are underreporting
these behaviors?
Yeah.
As you know, it's really hard because there's no gold standard to try to get at. AdHealth and a lot of other studies, use the confidential self-reporting to report sensitive behaviors so that they don't have to tell an interviewer, what their experience was. There have been a couple of studies looking at really at consistency, not validity. So Don Upchurch, some years back, compared reports of sexual behavior between waves 1 and waves 2. There were some differences, some inconsistencies. One of my former students looked at retrospective reports at age of first sex at 2 different waves. There were some differences, but actually there was quite a bit of consistency as well. So I think in terms of consistency, it looks pretty good. Nothing's going to be perfect. But in terms of validity and accuracy, I don't really know how you get that. I mean, the only way people have been able to get at it so far is we know that if you have an adolescent talk to an interviewer, they're going to be less likely to report a sensitive behavior than they will in a self-directed interview. So, but is more and more accurate. I mean, it kind of makes me think of this classic quandary with sex studies where males are reporting lots of behavior and females are reporting not so much, and it's like, who are they doing or not doing this with? So it's one of those things that unlike other things. I mean, you can't test blood. I mean, you can do it in some ways for an STI or something, but I mean, just in terms of general reporting, there's just no way to really get at it. So, I think there was, and I'll come back.
Thank you for this talk. I like how you laid out the development of your research over years and decades.
It's been painful sometimes.
Well, that's good to hear.
I can tell you about some of the painful parts that I didn't go into.
But it ends up in this coherent trajectory. So I have one comment and then a question. My comment is from my perspective as a historian, and you might be familiar with Alan Brandt's work on STI, the history of STIs, but how your research really disproves something that was very historically emphasized, the idea of a ruined woman, that early sex or sex before marriage ruined young women for marriage because they got STIs and they were morally ruined, their reputation, and ruined young men for, especially during the World Wars, for military service and then, sort of like ruined their masculinity. So you probably know, like the Commission on Training Camp Activities and the National Social Hygiene Association had movies about this, showing, the shop girl who gets ruined because she has early sex, basically, with the poor, the guy who's going off to war, and he doesn't get to go to war, and she doesn't get married or do anything, basically, except work in the shop her whole life. And so it's just really interesting that those tropes have continued so much even to now that they have to be disproven now. That there's this enduring cultural idea about early initiation being,
Especially for girls.
right, and especially for girls, but not only being sort of not preferable psychologically or psychosocially, as you're referring, but also dangerous physically. Like you're going to get an STI and it's going to be your fault. And that's sort of the definite dominant theme historically. So that's my comment about that. I
Yeah, it's
appreciate.
interesting how persistent some of that stuff is.
Yeah.
And of course, culturally the culture makes a huge difference. I mean, if you look at some of the work that's been done in the Netherlands, for example, where it's a very different approach to sexuality. It's seen as normative, and parents are accepting that their adolescents are having sex. They talk about sex. There's comprehensive sex ed. It's just such a different outcomes because the whole culture and the way it's approached is so different. So I don't know if that will ever happen here, but in the U.S. But
Well, at least in public health, we can stop telling people that you're going to be ruined for life and catch an STI if you have early initiation.
depending on the school district.
But the second thing was a question, and this is less informed with your new work. I'm interested in that sample of 2000 and whether you're going to be able to, stratify by region or even look at the ones who were in 7th grade in 94, 95 versus the ones who were in 12th grade. Because my guess, just as a member of the public and a member of sexual minority group, is that those two, the 7th graders and the 12th graders, are very different cohorts who experience very different social realities.
Right, and I think that's why we're like the postponers group. I mean, the fact that they're older, I think that's a cohort effect.
Yeah, so I was wondering if you're going to be able to tease out these cohort effects and also by gender even the effects.
It'll be, it's a great question because it's even with 2000, when you start parsing it in these different ways, then obviously you get, some very small cell sizes and unreliable estimates. And so we'll see. I mean, we're going to try to parse as much as we can because we think it's really important to understand the experiences of different cohorts and males and females in particular. But, I don't know how far we're going to be able to and I don't know if the latent class analysis that we're planning to do, I don't know if that's going to be helpful in this regard or not. Our goal would be to distinguish as much as we can, but I don't, we'll just kind of have to see how it plays out. So I think there was a question back there.
I'm really, interested in your idea of risk behavior only being risky in certain contexts, and how, your research bears out the thoughts that early sex or multiple partnering is only risky within certain contexts, and you're not doomed to these long-term negative outcomes. So I was curious what you thought then were the most important sort of indicators to look at. If it isn't the early sex or the multiple partnering, where should we really be what should we be collecting data on, and what should we be sort of putting into our model to understand when is early sex, when is multiple partnering really problematic?
I guess one thing I would think about would be whether, and this is going to sound very conventional, I know, but whether there are other issues that are coming into play. Are they having trouble in school? Are they using substances? And I don't mean to imply that sexual behavior is a problem behavior, but in fact, empirically, it does co-vary with these things. And I think it's the youth who are engaged in a lot of these different arenas who are more likely to have some struggles to get through. It's, one of the tricky things for public health, I think, is that because there is so much individual variation based on culture and context. We would love to have a one-size-fits-all kind of intervention, and the fact is that that's just not really possible. In fact, there was this, people always worry about if you ask questions about sex, then you're gonna make kids go out and, they must think, oh, well, they're asking me about this, so I should be having sex, obviously, and they're just gonna go right out there and do it. Well, there's no evidence to support that. And wouldn't it be great if that were the case? Because then we could say, did you brush your teeth today? And then they'll go out and do it, So anyway, but it's a little bit off the track, but I think and this is where, again, I think the smaller studies can come in to try to capture a more holistic picture of the context in which the adolescent is in. I mean, AdHealth did collect a lot of that data, but still, it's not the same as it's sort of complementing it with qualitative information about other aspects of their lives and how that intersects with the experiences that they're having sexually or with substances.
Just a little poll, how many are parents in here? Okay, so you see the hands? All right, so the two things that you said really came out of this is that early initiation's not bad.
I tell that to every parent.
My historian here says the persistence of these tropes. So would it surprise you that after these facts, this science, that these parents will still promote the trope for their kids?
I would hope they wouldn't promote the trope of you're doomed. I could certainly understand promoting, a thoughtful approach to when you.
Like, if you do this, it's bad.
Yeah, that I would not propose that people do, because I don't believe it.
Don't do that anymore, right? That's what I'm hearing.
No, what I would propose is that parents should talk with their kids about sexuality from a very early age. Not, don't have the talk when they're 13. Start talking about sexuality in a developmentally appropriate way from the very beginning, so that it's not a stigmatized topic. It's something that you talk about with your parents, that you feel comfortable talking with your parents. And of course, that's hard for parents, I think, for two reasons. One is they may not feel comfortable doing that. They may not feel qualified to answer some of the questions that may come up. And I think also that parents sometimes mistakenly believe that they don't influence their children's behavior or their attitudes. And that's wrong. Parents have a lot of impact on their kids, even if the kid's pretending like, I don't hear what you say, I don't care what you say. In fact, they do hear what you say, and they do care what you say. So I think parents underestimate what they can do for their kids to help them have a healthy lifestyle. Yes, Sandra.
I want to shift gears for just a second and ask two questions related to methods. So early on, when you were talking about AdHealth, you said you had an over 80% or around 80% retention rate. Now, for those of us who may, if we don't now, at some point in time might be interested in longitudinal research, but even those of us who are trying to do an intervention over 2 or 3 years, what are the things, that you learned about how to do good retention?
Contact. One of the interesting things about, and one of the reasons that it was a struggle in AdHealth, is that the original project only intended to collect 2 waves of data, 1 year apart. And so at the end of the second wave, nothing was done to try to get the kinds of information that you would get to follow up people. So, other people we can contact, your friends, panel maintenance kinds of things like sending birthday cards and newsletters and all those kind of things to kind of keep people in touch. None of that was done. And so at wave 3, when people were 18 to 26, and none of that stuff preceded it, as you might imagine, it was really hard. Because one, there wasn't anything to kind of start from other than the original parent who was interviewed. They were at a very mobile part of their life. They were going to college. They're getting jobs in other places. They're using cell phones, not landlines, and it was really hard at wave 3 to get a decent response rate, and that's because none of those things have been put into place. We're trying to do a better job of that now with panel maintenance and sort of checking in with people more frequently and doing tracing and so forth. So, but I know in the Cairns at the Center for Developmental Science at UNC, they had a longitudinal sample that they were brilliant about it. I mean, they regularly birthday cards, how you doing cards, all of those things. It was a relatively small sample, but still, it's a lot of work to do that. But I think that's what makes the difference, is just staying in touch and also having a good experience with the study. If they're feeling like they're that they're enjoying the experience of being in the study and that they're treated properly with respect, and they want to do it because they feel like it's an investment on their part and they're enjoying that investment. So, but it's hard. Oh, oops, sorry.
Can I ask a follow-up, and then I want to ask a question about your new study. So, do you share? There are lots of publications, obviously, that come off of Ad Health. How do you share the findings of the different, studies off Ad Health with those participants, or do you? Yeah.
We don't systematically do that, and some of that's because a lot of the findings are kind of depressing. So, you don't want to send out gloom and doom to all your respondents, but there is a place on the webpage where respondents can click on it, and it's targeted information for them. As part of the recruitment process for Wave 5, we did put together some materials that had some headlines of articles that were particularly noteworthy, and some snippets of findings, because we were trying to help them understand how important they were to the study and what the contributions were that they had made by being in the study. So we do some of it, but it's not part of what we regularly do. But it may be going forward, I think, and especially now that they're older and maybe have a little better perspective on things. I think that's a tool that we should probably look at more closely. But they can also go onto the webpage, on the Ad Health webpage, there's a bibliography that lists all the publications that we're aware of that use Ad Health data. So if someone wanted to, they could go there and see everything that's been done with Ad Health. And they know what the study is, so it's not that hard in this data to find out a lot of information.
Can I ask one more?
Sure.
Cede my seat. All right, give up my seat. You talked about, and this is a question I know some of our doctoral students have, about how do you go about the process of survey development, and instrument development. And some of us have slugged through that process, wondering later what were we thinking. So could you talk for a moment about how your process for doing that module development?
I think it's probably a little different in Ad Health than it may be in some other studies. And that's because, one, the goal, this is both the strength and a weakness of Ad Health. The goal was to cover a lot of ground so that researchers could use it for a lot of different topic areas. So there's two implications. One is that you have a lot of scope, but not as much depth as you would for a study that's studying X. The other thing is that the scope is partly a function of space. Even with an hour and a half interview, which is what's been done up to Wave 5, that's a lot. That's a big burden on respondents to do an hour and a half survey. And in the case of Ad Health, in addition to NICHD, other institutes and agencies were contributing funds to support the survey. And so there's competition basically for, okay, I gave you $500,000. How many questions are you going to give me for that? And literally, that's the conversation. So it's partly balancing a lot of different things. There's the requests of the donors. There's the unique pieces of the survey. But for a longitudinal study, there's these unique things that AdHealth has that you don't see in other longitudinal studies. So a couple of examples that I've mentioned to some folks today is there's partner violence questions that have been asked since adolescence going forward at every wave. And we decided at wave 5 we were going to keep those questions because it's a unique piece that AdHealth has that you don't see in a lot of other studies. Same thing with sexual orientation, looking at changes over time, longitudinal assessments. I was telling someone earlier that the question is flawed. It conflates attraction and identity. And so we had to decide, should we keep this question for the purposes of longitudinal consistency, or should I put in a better question? In that case, I decided to keep the flawed question because it was so unique to have that question over time. So I think if there aren't 500 chiefs in the room trying to drive the survey content, then in some ways it's easier, especially if it's a theory-driven study. You can really sort of think about, okay, here's the key concepts that we need to ask about. Do a survey of kind of what's out there in terms of measures, and so I think the process can be very different. That's actually one thing that I'm looking forward to on this sexual orientation ancillary study to AdHealth, is that it'll just be Kareth and me making the decisions about what goes into the survey, so we can really apply the theoretical priorities that we think are most important. But it's a web survey too, and so it's not going to be a 90-minute survey. It's going to be a 30-minute survey. That was one of the interesting things with Wave 5. We went from an in-person, computer-based, self-administered for some stuff, interviewer-administered for others instrument in the home. And at Wave 5, we had to go to the web and mail surveys. And it had to be, the conventional wisdom is you don't go longer than 20 minutes on a web survey or you get break-offs. And we thought, well, but that's all based on cross-sectional samples that are selected to do this kind of work, and they're small, they're convenient samples. Is that really going to play out the same way in a sample like AdHealth that's been engaged with the study for decades? But we didn't know, so we put in all these experiments where we had an A module and a B module of about 20 minutes in length, and then a singular module and on the web and on the paper backup. So we had like 9 instruments that we were fielding. And it was interesting because what we learned was with a longitudinal sample, at least with this longitudinal sample that's been engaged for as long as it has, even if they had the option of stopping after module A and coming back next week, they tended to plow right on through and just do the whole thing at once. They were used to a 90-minute survey, and this was, a 50-minute survey when you put them both together. So maybe that was part of it. But we had no idea if that was going to be the case or not. So happily, we were able to later change it to just one instrument. But and the other interesting piece about that is we weren't sure how many respondents would want to use the paper teleform survey, and we hoped that most would go to the web, but we didn't know for sure. And so the paper survey, we wanted them to be as similar as possible to avoid mode effects within even just Wave 5. And so the paper survey kind of drove the web survey. In the past, we've been able to do all kinds of fancy programming to do skip patterns and things, but if we wanted it to look as similar as possible, it's a much simpler instrument because it had to sort of mimic the paper. So it was kind of like old technology driving the new web technology. So anyway, our interesting experience. Wave 5 has been interesting. There's so many. We did a lot of experiments, and the upside is that we will make some good contributions to the literature on methods, when you're making these kinds of changes, because a lot of studies are going to continuous interviewing and to web-based surveys. So I think we can hopefully make some contributions on that, but it really has been very challenging to make that change. But it's happening. Yes.
I'd like to follow up on the web, and transitioning to the web survey. A lot of the new web surveys, because people are getting very good at kind of gaming the system, they are including empty questions like don't fill this out if, when you get to this question, skip this question. And I wanted to know whether you implemented that in the web survey or because you kind of trust your sample.
We did not do that. I mean, you can kind of tell when people are gaming it a little bit, but yeah, I mean, we didn't put that in. I was going to say something about that. Now I've forgotten it. We found that that actually the missingness is not a problem, that may be part of it may be a function of the sample and its long-term engagement with the study, but we do, quality analyses to look at both skipping over an entire section and also item missingness, and the data quality looks really good. So the one thing we did do, this is what I wanted to say, was we had should we put that little bar that shows how far along you are into the survey or not? And we decided we'd go ahead and put it in, and that was a mistake. I mean, where we have break-offs, we don't have a lot, but where we have them, that's where they break off. It's like, I'm only halfway through. So if I were to do, we won't do that in Wave 6. We won't put that little progress bar in there. So it's interesting, these little tidbits. Yeah.
Any other questions?
I have one, but I'm hesitant to ask it. I don't want to leave on a doom and gloom.
Okay. Well, I just scared all the
Somebody
doctors.
else can ask a question after my question.
Can you go back to your, at what point the effects of having early sex are negated slide?
I'll just back up and you can tell me which one you're referring to.
Your student who's now at Virginia Tech.
Oh, yes, yeah.
So, okay. So I do work on HIV in young women in sub-Saharan Africa, and so I'm looking at this, and I think it's fantastic. But by the age of 24, if you've gotten an STI, it's completely, I mean, your chances are basically the same. But I look at this and I think, but if that STI is HIV,
yeah. Yeah. Right, but it's a lingering issue.
Yeah.
Careful. Yeah. That's true.
Okay. And so
yes.
I just wanted to see at what age really.
Yeah. And this does not include HIV.
Okay.
Yeah.
Right. No, I figured it wouldn't because it's But this, if it were to map onto different populations, then it is.
And it's also kind of interesting because, I mean, that's the peak, when you get up into the 20s, as you know, I mean, that's a peak period for STI. So, but again, this is just relative to when they had their first sexual encounter. AdHealth did test for HIV at Wave 3 when about that age of the early 18 to 26. And it was an interesting process because there was a scientific advisory committee, and there was one group that said, don't bother testing for HIV. It's a population-based sample. The incidence or prevalence is going to be so low that it's not going to be worth all that money. And then there was another camp that said, but how do you know that? We only have surveillance data. We don't have population data of this large of a sample. So Dick Udry, who was the PI at the time, decided to go ahead with it and test. And the first camp was right. The prevalence was very low. And in fact, it was so low that only one paper could be written about it because there were significant deductive disclosure issues because the size was so small. So, fun with surveys.
Interesting to think about how it maps.
Yeah.
How the messaging would maybe map differently in a high HIV prevalence context.
Yes.
Right?
Yeah. And obviously this isn't the only factor that's relevant. I mean, this is just one indicator of age at initiation.
Yeah.
So.
Yeah, thank you.
You mentioned earlier that you compared the U.S. with the Netherlands, talking a little bit about how the context may be different. And so I'm just wondering, has there been research that's comparable to this and thinking about, I guess, early age and sexual initiation and then subsequent later outcomes that sort of does dispel this idea that it leads to negative outcomes, at least in contexts that may, like the Netherlands, where there is a more, I guess, they're not so afraid to talk about sex, they're just accepted as a normal part of development.
Yeah, I mean, I think there's plenty of smaller scale studies out there that look at the issue and try to get a more holistic view on, take more into account than just we tried to take more into account, but that's still kind of, counting beans in some ways and not really getting at the relationship qualities. And so there is some literature. I can't give you some citations right off the top of my head, but yeah, there's definitely some work going on out there that tries to better contextualize those behaviors and experiences.
So first, join me in thanking Dr.